Welcome to Lung POCUS. I hope this video will help you in building your basics for lung POCUS. And in the initial part of the video, let's discuss about the patient position, the probes we'll be using, and the probe placement on the patient. So ideally, the patient should be lying flat with his hand behind the head so that we get the complete exposure of his chest to examine. But if the patient is dyspneic, he cannot lie flat, and in those conditions you can prop up the bed to 45 degrees or make the patient sit. Whichever is comfortable, you can do POCUS in that position. Okay. And coming to the probe, you can either be using linear, curvilinear or phased array probe. Ideally, high frequency linear probe is used to visualize the superficial structures like pleura clearly, and low frequency probes like curvilinear and phased array probes is used to see the lung parenchyma or any other deeper structures very clearly. Okay, and remember one thing, the phased array probe is very small and it is used for your cardiac POCUS, and that probe can easily fit between your ribs. So if you want to examine the posterior parts and the dependent areas, you can put it between your ribs and clearly see if there is any effusion and all. This phased array probe is used, we particularly choose the phased array probe if you are suspecting that. Okay. So that's about the probe. And how do you hold the probe? You have to hold the probe like a pencil, and every probe has a probe marker, and that probe marker should be facing the head end of the patient. Okay, so that is how you hold. And make sure you have an ultrasound setting of preset of lung, and there will be a screen marker, and that should be always on the left. Except for cardiac POCUS, it will be on the right. I'll explain the reasons in the cardiac POCUS video, but for every other POCUS it should be on the left. Okay, so that is about it. And now you will place the probe on the patient. Where do you place it? There are a lot of protocols telling, like 12-point protocol, 9-point protocol, 8-point, 6-point protocol, a lot. But for the purpose of the video, we'll be talking about blue protocol, which emphasizes to see the lung, look at the lung at 6 different points, 3 on one side and 3 on other side. The first point, R1, L1, it is in the second intercostal space in the mid-clavicular line, and the R2, L2, it is in the fourth intercostal space in the mid-axillary line, and the R3, L3, it is in the 10th or 11th intercostal space in the posterior axillary line. So this R3, L3 point is called Plaque's point. So this point is very important because we know pneumonias are more common in the lower lobes, and this Plaque's point helps us to see the lower lobes and the posterior aspects of the lung clearly, this Plaque's point. And also if there is any effusions, they collect down, because of the gravity they'll be on the lower side, and you can clearly see them in the Plaque's point. And one more thing is, this ultrasound is very sensitive in detecting pleural effusions. It can detect a small amount like 30 to 50 ml of fluid also, it can detect it. If you are taking a chest X-ray to detect the pleural effusion, you need at least 200 to 300 ml of fluid to get the costophrenic angle blunting. But this ultrasound is very sensitive, it detects 20 to 30. Also this is used to guide your procedures like thoracocentesis procedure or ICT placements and all. This ultrasound is very useful and very sensitive too. So that is about the lung points, a brief about lung points. So now you are placing the probe on the patient. You place it on an R1. What do you see? So you see this picture. In this picture, you see these 2 vertical black lines. They are nothing but your rib shadows. Okay, and in between these 2 vertical lines, you see a horizontal line. It is your pleural line. So if you see a motion picture of this one, you can clearly see a shimmering movement in the pleura. They describe it like an ant-like analogy. It means nothing but your parietal and visceral pleura are gliding against each other. When you see that, you can immediately rule out if there is any pneumothorax, air. If there is any air, it wouldn't slide. So you can immediately rule out air at the point you're looking. You can rule out pneumothorax. So that is about the lung sliding. So it is called sliding, and that's about the lung sliding. So what are all the conditions you wouldn't be seeing lung sliding? One thing we already discussed is pneumothorax. What all? So if the patient is holding their breath, in those conditions also you cannot see any sliding. So what you say is, take normal respirations and check for the sliding, and you'll get you'll see the sliding. What if you didn't see any sliding? Then what you will do? Then what you'll do is you'll move your probe a little down till you see any sliding. So if you appreciate any sliding, the point of no sliding and sliding is called lung point, and it is seen in pneumothorax. Like any mild pneumothorax or moderate, you can see it. But if it's a tension pneumothorax, you cannot see any sliding. And first of all, tension pneumothorax is a clinical diagnosis. You will never be using a POCUS and waste your time. You should never be using a POCUS. It will waste your time. It's a clinical diagnosis. You have to immediately go the management. That is the thing. No sliding, don't check it for tension pneumothorax. It's a clinical diagnosis. You will see it whenever the patient is holding their breath, or they're having any apneic episodes, or in pneumothorax you wouldn't be seeing sliding. And what all other conditions? Imagine if a patient is intubated and you want to see if the both lungs are equally aerated or not. You can use POCUS. For example, in this case scenario, I see a sliding in the right side of the lung, and I do not appreciate any sliding in the left side of the lung. What does that mean? It means they might have done right main stem bronchus intubated. You have to pull the tube a little higher up. Okay. In another case scenario of a similarly intubated patient, now you cannot appreciate sliding in the right side of the lung, also in the left side of the lung. What does it mean? It means they might have done wrong intubation. They might have intubated into the esophagus. Okay. So basically we will never be using POCUS to confirm the intubation and all. The gold standard is capnography to confirm intubation. Otherwise, apart from it, you will be seeing the 5-point auscultation, 5-point lung auscultation, or you visually inspect to see if there is equal chest rise or not. Or you can take a chest x-ray and confirm the position of the ET tube. You have all these things, and ultrasound is like a last resort, and you will never be using it, but it's just an application for us to put it in our mind. Okay, so in those conditions you will use. And what all? In what all conditions you wouldn't be seeing sliding? So whenever there is any adhesions between your pleura, or when any part of your lobe, any lobe of lung is removed, lobectomy, then also you cannot appreciate any sliding. So that is a very brief about no sliding and sliding. Also, remember, whenever you see sliding, put an M mode, you will see a seashore sign. No sliding, put an M mode, you will see a stratosphere sign or a barcode sign. Just to confirm it, just put an M mode and see, you will be able to see these signs. Okay. And now coming to the next concept, the A lines. So A lines are horizontal lines parallel to your pleura. So what are these lines and how are they formed? So these are nothing but your reverberant artifacts formed between two strong reflectors. One is your air in the lung and the other is the pleura. So we all know that air is a very bad conductor of ultrasound waves. When the waves are reaching to the lung parenchyma, the air in the lung parenchyma, they reflect the ultrasound waves to the pleura. And what does it pleura do? Pleura reflects again, and they forms this A lines at equidistance, a lot of A lines at equidistance. You don't need to understand the mechanism or remember anything. About the mechanism, but remember one thing: A equal to air, and these lines are formed because of the ultrasound waves being reflected by the air in your lung. Okay, so where do you see these A lines? A lines are seen. So in a normal lung, it is filled with completely air. You can see this A lines. So what are other conditions? So so in pathological conditions where your lung is filled with air, trapped with air, like COPD, asthma, you can see A lines. Also, one more interesting condition, pulmonary embolism. So pulmonary embolism, your pulmonary artery is blocked. Your lung wouldn't be showing so much pathology. It will be coming in the later stages, but initially you wouldn't be seeing it appreciate any much pathology. It will be with air. So there also you can see A lines. So as I said now, your normal lung, COPD lung, and also the pulmonary embolism, they'll be having sliding A lines. So how do you differentiate all these three things? And is POCUS really helpful in differentiating, these three? Differentiating enzymes, POCUS is never used as a diagnostic tool. It will help you in your diagnosis. So will your POCUS really help you? To differentiate these conditions? Yes, it is. One thing you have to remember is always correlate clinically. So you see the patient being dyspneic, you see normal sliding in A lines, and you say the patient is normal? No. Then you check the patient free veins. If the free veins are having any any thrombus, then it is pulmonary embolism. You have to immediately diagnose it as pulmonary embolism, because if there is any thrombus there, it comes to your pulmonary arteries and blocks, so you will diagnose it as pulmonary embolism. If do you not see any if you don't see any thrombus in the free veins, then check your heart. Even in the pulmonary embolism, check your heart. So I'll initially talk about pulmonary embolism. So because of the thrombus in the pulmonary artery, there will be an increased pressure in your right side of the heart. So what happens? Your right side of the heart dilates, your right ventricle dilates, and the interventricular septum is there, in the right ventricle, that is pushed towards the left. That is pushed towards your left. Normally your left side of your heart, left ventricle is bigger, but in this condition your right ventricle dilates and it gets bigger than the left. And when you see the parasternal short axis, in this image, this is the view. In this image, you can see that your right ventricle is like a O circle, and your left ventricle will be like a crescent shape. That is a normal. But what in pulmonary embolism, as it dilates, the interventricular crescent shape, which is that flattens, and your O becomes a D. Your O becomes a D. Okay. So that thing you can appreciate. And also, when you see the apical four-chamber view, in your apical four-chamber view, the free wall motion of your right ventricle decreases. The free wall motility. The free wall is the one wall, not the interventricular septum, the other one side of your right ventricle. You can see decreased motion in there. But it is pressured in the apex. Why? Because apex has more blood supply and it tries to compensate and pump against the pressure and everything. So it it will be the motion will be there, preserved there, but in the free wall it will be decreased. And this is called McConnell sign, and it is seen in pulmonary embolism. COPD, and coming to COPD, it is also a condition in which your lung is damaged and your back pressure in your heart, right side of your heart increases. So what happens here? So this is a chronic condition. Here your right ventricle dilates, but as it is a chronic condition, your heart try to compensate it, and there will be a wall hypertrophy. The right ventricular wall hypertrophy will be there, and the dilatation is also not as big as in pulmonary embolism. And this wall hypertrophy is not seen in pulmonary embolism again. Okay, so here you can see the wall hypertrophy, and also dilatation is not as big, and then also the hypokinesia I was talking, that will be there will be a global hypokinesia also in the apex. Everything will be reduced, but in a little manner, and it will be globally. There will be no difference like the apex is preserved or the free wall. There will be a global right ventricle hypokinesia. Okay, that is about that is how you help. That is how your POCUS help you in the diagnosis of your normal lung, COPD lung, and the pulmonary embolic lung. Okay, so that is about A lines. And now coming to our next topic, B lines. So B lines are vertical lines. They extend from the pleura till the bottom of the screen. if any lines that end in the middle of the screen, like that do not reach the bottom and end in the middle, they are not B lines. They call it like Z lines, and they are normal. You don't need to worry if you see Z lines, okay? Also, B lines, to diagnose, B lines are seen whenever there is an pathology, like an increased density in the lung. You can see B lines. Only when there are more than 3 B lines in an area, then only you say there is an underlying pathology. If you see 1 B line, 2 B line, it is fine. It is fine, there is no pathology, but it's more than 3, then only you diagnose it. So I said B lines are seen whenever there is increased density. So what conditions there will be increased density? So one is whenever there is any fluid in your lung, your density increases. Also when your lung becomes shrinked, like atelectasis, then also there will be an increased density. Okay, so we generally remember fluid, but also in these atelectasis, all these conditions, lung comes collapse like this, there will be increased density. You can see B lines in those things also. Also coming to the fluid, remember one thing, if it's a pneumonia, you can see B lines in a particular lobe of the lung, particular side on a particular area of the lung, but the other side would be normal. But if it's a pulmonary edema, you will have diffuse edema, and you will see diffuse B lines in both the lungs. So that is how you differentiate a pneumonia from a pulmonary edema. Okay, so these are the basic concepts: lung sliding, A lines and B lines. And using these three fundamentals and using the blue protocol, you can diagnose 6 pathological conditions, and I will put the blue protocol in the end. You can easily understand that. And also I'll try to include any images I find online in the end of the pathological images I find online in the end of the video. And I thank you for watching the video till here. I hope it built a little basics for your understanding. And thank you so much. If you have any questions, comment down below. I will try to answer them. Thank you so much.